Epoupa Flora from Public Health on the title Descriptive Study of the Older Adult Receiving Antiretroviral Viral Drugs in Mater Misericordia Hospital, Afikpo, Southeast Nigeria.
Okay.
Yeah.
This is a study of the characteristic of elderly patients living with HIV and accessing care at a faith-based hospital in Southeast Nigeria. Elderly means being 50 years or old or more. With the expansion of the life-saving, highly active antiretroviral drug, the number of elderly is increasing in our clinics. So the activity is driven towards prevention, and case finding are not targeted at this age group. The study examined the proportion of elderly who had first contact with the facility during January 2014 and December 2015. Their immune status at entry point and their duration of care related to some socioeconomic factor were observed. So, this study is an observational method. The study was carried out through an observational study method, and data were abstracted from patient medical record and registers. A data collection tool was designed and tested to ensure all required information was available before the start of the study. Eligibility criteria was clearly outlined to ensure homogeneity of the study population. A simple chi-square were used to analyze the findings. So the problem, what prompted this study? With the advent of highly active antiretroviral therapy, HIV-infected individuals could live longer and healthier lives. This resulted in an increasing number of individuals who were diagnosed at a younger age who lived beyond 50 years of age. Older adults are usually diagnosed late with advanced disease in the US and accounted for about 26% of population of HIV-infected persons. This population of HIV-infected individuals are usually underrepresented in planning, prevention, and treatment programs. So the rationale of the study, there is lean literature in Nigeria that describes the socioeconomic context of this patient category. This study will give an insight of the peculiar clinical and social characteristics of the older adult at initiation on therapy and during the course of the treatment. Understanding the important needs of the elderly infected with HIV will help design care models that will adequately sustain their health and well-being, as well as retaining them in HIV programs. So the objective of the study was to establish the proportion of older adults at enrollment among HIV-infected adults enrolled at this facility in 2014 and 2015, and to describe the immune status of this elderly at initiation on antiretroviral therapy, to determine the proportion of older adults 12 months after enrollment in HIV care and reasons for care loss. There's an omission here. To determine the relationship between socioeconomic characteristic and retention in care or loss to care. So the method. The target population was older adults 50 years and above who are receiving HIV care at Mater Misericordia Hospital. The inclusion criteria was all older adults newly enrolled into care in 2014 and 2015 as treatment-naive patients, that is, patients who never received ARVs prior to their contact with the facility. Both active and inactive patient medical charts were included. So both patients who were still on care and patients who had stopped care for any reason were included in the study. The exclusion criteria was older adults transferred in the facility from another HIV care center already receiving ARVs and other adults who became 50 years or above in 2014 or 2015. So the method. A review of the enrollment register was done to estimate the proportion of elderly adults who were newly diagnosed and enrolled from the general population of patients from January 2014 to December 2015. A systematic review of medical charts of these elderly newly enrolled in these 2 years was carried out, and demographic data was documented using a data collection tool. The following data were abstracted: demographic, clinical stage, and economic status. So, we define the terms as older adult 50 years and above. Care status was active in care, dead, lost to follow-up, transfer outpatient. The immune status was the measure of CD4 expressed in a range. So, the result and data analysis. All medical charts of patients 50 years and above eligible for the study within the review period were found, which was constituting 100% of the target population. So, all newly enrolled patients who were 15 years and above, all their medical charts were found and were included in the study. So, we had the demographic. In the demographic, we have a 41% female and 51% male that were in the study. So, by marital status, our findings was that 48% were married, 5% were never married, 8% were divorced, and 40% were widowed. So, for their economic status, by source of income, we had 7 civil servants. 33% of the patients were civil servants. 33% were male among the civil servants, and 25% were female. 32% were farmers, males farmers, and 35% were trader among the males. Among the females, we had 25% civil servants, 40% farmers, and 35% traders. So the proportion of older adults in the clinic, it was seen that older adults accounted for 25% of clients in the clinic, that is at initiation, and while all other adults accounted for 75%. So by immune status as enrollment, it was noted that 200 to 499% 499 CD4 cell count were 44% of the population, and 46% had a CD4 less than 200, and only 10% of the older adults had a CD4 of 500, which means that only 10% of older adults who were newly identified were healthy, but all other adults, 44% and 46%, were already at advanced AIDS condition. So at 12 months, we realized that 20% of older adults who were newly enrolled, were lost to follow-up, 13% were dead, and we had 63% that were active. So 4% were transferred out. So there was the total loss to care among the older adults were 37%. So we also noticed that the family factors that could be related to their care status, we noticed that 63% among the married persons were active, while 8% were never married. The part of the active population were never married. So there were fewer patients who did not have a partner who discontinued their care or died. So which tends to conclude that being married was a significant factor to maintain patients on care. So relationship between source of income and care status. The self-employed older adults were retained in care more than the farmers and civil servants, and that means that those who already had a source of income that was personal, not depending on any other source of unemployment were more likely to be retained in care, and civil servants were more likely to be lost to care. This is quite disturbing because it is expected that civil servant in Nigeria has a stable income and will actually were supposed to be more likely to be retained in care. So the discussion, the proportion of older adults at this clinic was 25%, which is higher compared to 14% which was found in the literature, widely found in other countries like South Africa. And 90% of the older adults had advanced disease at entry into care, which agree with existing knowledge. The marital status did not significantly impact on care outcome as suggested in some studies. The self-employed were more likely to be retained in care at this facility. This suggests a financial strength that contributed to this outcome. Civil servants and farmers accounted for a high number of loss to follow. It will be necessary to carry out more studies to understand the peculiar reason in these groups. Farmers are actually among the population of the poor population in the country, and if they were affected, we will understand why farmers could be affected by this. So in conclusion, the elderly newly enrolled account for 1/4 of all adults enrolled at this care facility, which is a significant number. And because of late entry to care, the provider may need to target this population group during HIV testing drive and initiate programs that will support the immune reconstitution of the elderly. A mixed method of study will probably be necessary to show the relationship between care status and source of income as well as marital status. So in my own understanding, it was actually inconclusive. My study could not conclude if marital status and source of income were directly related to care status. So the limitation of the study, this older adult population is far from being representative of the total population of elderly who are HIV affected. Just like I said earlier, we limited the inclusion criteria to those who were newly enrolled and those who actually never had contact with ARVs. So it was just the newly enrolled that was our target population, which is far from being representative. Probably those parameters of care status, taking a larger population of the older adults with many other characteristics, could actually give us a better view of the relationship between socioeconomic and care status. Thank you very much.